All right, folks. So I know it's been a long morning. We've had some amazing presentations, so it'll be a hard act to follow. We'll try to keep this interesting and move through quickly here. And Avnish, thank you so much for fitting us in. We were kind of a late last minute add-on because of our own communication issues. All right, so we wanted to talk about something beyond the numbers. How do you pair textual data with natural language processing and a specific use case for it? I have with me Nathan Cannon and David Foley, who are part of our team. I wanted to introduce the rest of our team, some of whom can't be here. So Neha Gupta, myself, Alyssa Twan, Dr. Krajnewski, who's our advisor, and it's always amazing. David, Nathan, and then Christian Park as well. So a quick outline of our talk today. We wanted to talk about, health literacy, who is affected, and the readability of hospital discharge summaries. We wanted to talk about artificial intelligence and health equity, and also what our solution is, which we call Simplify. We'll talk a little bit about future directions for AI in healthcare as well. So first, we just want to discuss a little bit about health literacy and health disparities, and to provide you with some background framework that we're using to develop the solution. 9 out of 10 adults in the United States are affected by health literacy issues. And that's defined as, health literacy is defined as the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and for others. Now, who does health literacy affect? It affects most United States adults. It's associated with a range of social and individual factors. So it's associated with general literacy, geography, education, employment status, income, health insurance coverage, and preventative health activities. We know that 20% of adults in the United States read below the 5th grade level. The United States Department of Education has published some data about this. In 2017, the Black and Hispanic American populations had a low reading level, while most people in the white American population had a high reading level. At the same token, we know that seniors and young adults were found to have the lowest health literacy, and seniors are most likely to use more healthcare services. They have more chronic conditions, and they take more medications. So at our institution, discharge summaries are composed of 2 sections. The first section is meant for medical providers and details the patient's hospital course, any pertinent medical information related to the care that they've received, and medications prescribed to the patient that will be continued at discharge. The second section is written for the patient and consists of discharge information related to the post-hospital care. So individuals with limited health literacy can encounter barriers to interpreting basic health information, such as hospital discharge instructions, medication dosing instructions, and the timeline for follow-up appointments. So we know that a lot of the content here is written at too high of a reading level. Patients may also overestimate their perceived comprehension of discharge instructions compared to their actual comprehension. And then low health literacy can lead to increased hospitalizations and use of the emergency department. There was a study by Chaudhry and group that where the research were able to improve the readability of discharge summaries by breaking up long sentences, changing complex terminology, and assessing content with readability calculators. In this study, they found that 30-day patient readmissions in the post-hospital setting were reduced by 50%, which is a huge change. So we know that there's evidence here that interventions related to readability and health literacy can work to improve patient health outcomes. I'm going to skip some of this because we're on limited time. I'm going to hand it over to Nathan to talk about artificial intelligence and health equity.
Thank you, Ravi. So yeah, next we are going to take a look at the intersection of AI and health equity. And this is particularly relevant because healthcare represents one of the largest areas of expansion for AI due to its vast wealth of data that it has available. So it's important when talking about big data in healthcare to avoid creating or perpetuating inequities. So I think we all understand that quality means that everyone gets the same thing. If we treat the figures in the graphic equally, so you can see on the left side, Each gets their own crate to see the baseball game, but the problem is that the shortest can't see at all while the tall one clears the top by a mile. Equity, on the other hand, involves principles of justice or scarce resources. In this graphic, the crates are distributed according to need. This makes sure each people group meets a baseline standard of care and each one can see over the fence, so to speak. Next slide. So the problem is when we ignore principles of equity or even principles of equality, the reality of what happens is usually the opposite. So this happens in healthcare, whether we like it or not. In the last couple decades, the gap between US rural and urban mortality rates has actually tripled, and those without a college degree live 5 years less on average than those who have one. Also, the difference in life expectancy between patients in the highest and lowest income levels is upward of 14 years. So these inequities are reflected in the real life data used in AI applications. This is one of the biggest challenges to creating socially responsible AI applications in healthcare. For instance, we take the example on the right, say we're creating an AI algorithm to predict which patients are at risk for diabetes. If you train the algorithm to predict risk based on who has come in for treatment, your algorithm will not capture the needs of people groups that may frequently have diabetes, but historically go untreated. This creates a biased algorithm that will underpredict the risk of diabetes and thus perpetuate a health inequity. One obvious solution to this problem is to make top-down corrections for inequalities in the data. In our previous example, one might add an empiric correction to the algorithm to label those untreated groups as higher risk. However, the factors that put a particular demographic at higher risk are multifactorial and complex, and addressing only one factor will cause the algorithm to make broad assumptions about the demographic as a whole. And this can lead to overtreatment in some cases and undertreatment in others. So while this method could relieve some inequity, there's still room for improvement. So what is the best way to tackle health inequities with AI in healthcare? We would submit that the best solutions don't simply adjust for a barrier or obstacle, rather they aim to proactively eliminate the barrier or obstacle directly. In the graphic here, that means taking down the fence. In just a second, we're presenting our AI solution, which we call Simplify, aimed at alleviating inequities from disparities in health literacy. We came up with Simplify to decrease the gap between patient reading proficiency and discharge instruction reading levels, essentially lowering the barrier of communication between patients and providers and providing health equity by proactively addressing a systemic barrier. We believe this is a good example of using AI to address inequity in a socially responsible way.
Sorry, Ravi, you're muted.
Thank you, David. I just wanted to quickly introduce you to Simplify. Simplify is an artificial intelligence and natural language processing-based tool that's designed to be integrated into the EMR to improve the readability of discharge instructions. Our plan is to reduce health disparities by improving patients' understanding of their discharge instructions following a hospital stay to reduce preventable readmissions. Our goal is to empower patients to take control of their health outcomes as they navigate the health system and to better understand their medical conditions, the medication dosing instructions, and their timeline for follow-up. Our vision has just 5 simple pillars. It's really better readability of patient-facing communication, improved outcomes ultimately, transparency for patients, empowering patients and increasing their engagement, and improving health through communication. So over to you, David.
Okay, so here are some examples of the sort of thing that we would like this technology to do potentially. So the idea is here highlighted text is transformed into something that is easier to understand or more specific. So, or in fact changes the entire sentence altogether to be more readable. Right. So one potential use is to replace phrases like a cardiologist with information that's actually pertinent to the patient, right? Like the name of their doctor, or to take ambiguous language like persist. If you have such pain and it persists, please take measure of glycerin. Replace that with language that tells you specifically what persisting means, right? Persist for how long, right? You can take it this much up to this many times, right? All right, slide, please. So the algorithm is developed in the following way. This is a hybrid AI system that uses both rules-based text substitution and text clarification and artificial intelligence sequence-to-sequence transformer model. And all of this is trained on discharge instructions that are simplified by human translators, let's call them. So this is trained as a machine translation task. This is a sort of natural language task where modern AI has shown to be have really big advancements over the older techniques. So we frame this like the AI will see a piece of text and it will translate it into simpler English. And that is the idea at this stage. So we incorporate data augmentation from SNOMED-DT to generate additional examples to train on our downstream ML model. Slide. Okay, so here are some output examples of the actual model, right? Not an idealized model, but the actual model as it exists. So some of the simplifications you can see here are pretty reasonable. For example, take your medications as they're prescribed, so take them exactly as they are written. It replaces a phrase like primary care provider with family doctor. It replaces the word afford with can't pay for. Oh, I'm sorry. Yeah, so this is the human simplification. And then the AI simplification doesn't always match the human simplification, but even when it doesn't, it is makes reasonable substitutions a lot of the time. So for example, it has picked up family doc, right? Sorry. Okay, so here are some output examples that are a little less than ideal of cases where the AI so clearly has room for improvement, right? So in the one case, the human suggests a simplification that the AI just misses. Sometimes the AI will introduce characters or even entire words that don't make sense, or sometimes it will introduce entire phrases that are render the whole thing completely unusable, right? So this final example, don't stop medications without discussing with your doctor, it inputs this completely nonsensical phrase, do not put any first P first. And this is the kind of thing that you see from a limitation of the data set, right? When it encounters a word that it hasn't seen before, it will do something very garbled. And in this case, I'm thinking the word, the offending word is the phrase discontinue, right? If the model hasn't seen discontinue in the training data, it will not know what that means at all. And this is the kind of thing that has to be caught by rules-based checking of the results. And this is also part of why in the simplified framework, we don't actually envision the system as something that modifies the text, which is then handed off to a patient, but rather is implemented into a system where a clinician has to approve recommended changes, right? So the last person to ever touch a document is not the AI when it makes some kind of error, right? It's always has a human in the loop. Slide, yeah. Okay, so here are some metrics that we use to look at how the model has improved as we train it on more data. So on the left, we see a readability score. And we see that for the original instructions, the human simplifications, and the AI simplifications. Now, this comes with a very big caveat, right? This readability score does not take into account semantic content. It is based principally on length of sentences, complexity of individual words. So when we see that the AI simplifications are getting a lower score here, where lower means a lower reading level, which is good in our case, right? We want to lower the reading level. when we see the AI has the lowest score, that does not mean that the AI is beating human simplifications in terms of the readability, right? This readability metric functions more as kind of a coarse grain check on whether or not the model is making things more complicated, but it cannot check whether the semantic content is actually preserved correctly. So just bear that in mind. This is not a claim that the AI is better than humans. And on the right, this is just a map of how the performance of the algorithm improves as we expand the data set size. So a big part of the development of this work has gone into the actual manual labor of creating a data set that is useful and can be used to train this AI model. This is by far the biggest bottleneck on machine learning algorithms, is having a large amount of high quality data, which we have been producing.
All right, so just like David was mentioning, the biggest obstacle we encountered in building this tool was just the lack of high quality data. So we did find the simple English Wikipedia corpus, which is the standard for text simplification research, but it was surprisingly low quality and we had few good alternatives that existed. So for this reason, we set out to build a proprietary high quality data set for medical text simplification in order to power our technology. In order for this to take place, we had to get IRB approval, and then we were able to begin the data collection process, a QI process, and basic algorithm training. And then once we were able to collect enough data, we began algorithm testing, researching our interface, and solidifying infrastructure for data collection. This pyramid demonstrates how we collected the data used to build our AI algorithm. We believe that our solution is unique in part because the value of creating our own finely tuned data set. Step one of data collection represented the 50,000 discharge instructions we were given access to with IRB approval. They were for the 5 most common diagnoses which cause hospital readmissions as identified by Medicare and Medicaid. For our first iteration, we decided to focus on heart failure, which is the #1 most common readmission diagnosis. And then of these discharge instructions, we were able to translate 350 manually, and this was accomplished by 5 medical students within the course of a month. Finally, the third and final step was peer review and quality improvement, where each translation was reviewed by at least 2 translators, and then a word processor was used to eliminate any spelling or grammar errors. And this just ensured that the original content was preserved and that the text was fully simplified. Next, we'll take a closer look at step 2, which is the translation process. So the translation process was tightly regulated to ensure data quality. Our data set needed to include paired text, an original and a simplified version. And the simplified version had to match the content of the original very closely to make sure that we didn't change its meaning. Translators were trained to focus on parallel line-by-line structure to preserve text content, substitute out difficult words or phrases, and reduce complex sentences. Then readability scores were calculated by grade level. So here we have an example of the translation process. So the text on the left, you can see cardiac prudent low sodium is pulled from actual discharge instructions, and on the right are the translator simplifications. You can see how substitutions like heart friendly for cardiac prudent and salt for sodium are more likely understandable for patients instead of using medical jargon, which obscures the text's meaning. And then translators also broke up sentences where possible. So looking to the future, our plan still is to scale up data collection and improve algorithm accuracy. And we're currently working on the process of continuing data collection. Our goal is to reach 12,500 translations, which we expect will give us sufficient variety for each diagnosis. We've drawn up a detailed plan and budget to hire translators and additional roles over perhaps the course of a year for a cost of about $70,000. We've also studied our past data collection process and plan to streamline and improve it as we scale. We'll try and eliminate waste through steps like automation, division of labor, and other incentives that involve restructuring that process.
So Our simplified text database is the first of its kind in healthcare. In any machine learning and artificial intelligence task, data is king. With this in mind, we've endeavored to create a robust, multi-specialty simplified library that is reviewed by licensed physicians for accuracy and simplification. This in itself is a product, but so Simplify can be used to evaluate all patient-facing materials. If you kind of expand your horizon a little bit, you can include this on patient portal communication, information on medical apps, and popular websites like WebMD. We also, in the future, want to be able to adjust text to regionality, reading level by patient preference, and then obviously by language. What we presented to you was kind of just the bare bones of the product. We don't have enough time to get into what we think the UI interface will look like. Some of the obvious challenges with physician input, making sure they don't have too many clicks, making sure they have the final say before anything goes to the patient. But this was just kind of a very brief overview of what we're working on. All right. So just some challenges I wanted to talk about. You all may be considering pursuing your own AI/ML project, and many of you are already researchers, so understandably IRB approval is something you're all familiar with. But for us, it was difficult because this application was different. We had requested to get access to all discharge instructions from all admissions for these five major causes of readmissions over the past 10, 15 years. And that's a difficult ask. So how do you get that information out? The other thing we learned is that Cerner is very unfriendly in how its data is structured. So even though we had the FHIR standard, the discharge instructions don't fall into that realm. And so we actually have to go into each patient's chart and manually extract the instructions. There's no code that we can write to pull all the data that we need automatically. And that's very time consuming. The next thing is data quality. So when you compare two discharge instructions, if they're too similar, your algorithm is just going to be learning the same iterative thing over again. And when it's posed with something that's unique, it's not going to be able to change it or translate it appropriately. But the other thing is the translations that we're actually doing. So how do you ensure that, one, they're accurate, two, that they're consistent, the sentence structure is consistent between all of them, and a few other factors. And Nathan has been really instrumental in making sure that that data is clean and precise. Developing the algorithm is difficult. So if we had more time, David and Nathan would tell you about some of our concerns that, is the algorithm actually learning from the data, or is it just learning to substitute certain phrases? And then finally, and obviously scaling. How do you get enough data to train a NLP algorithm to produce meaningful results? And is that number 2,500 per diagnosis? Is it 10,000 per diagnosis? Is it 20,000 per diagnosis? We're going to find out, but there's no, I wouldn't say no, but there's very limited data and research out there about this right now. So we're looking forward to publishing our results soon. Just to recap, poor health literacy is a leading health disparity that has been linked to poor health outcomes. We can help reduce the impact of poor health literacy by improving the readability of patient resources and instructions. Artificial intelligence in medicine is not limited to only numeric and categorical data. We can apply it to textual data. And accurate and precise data collection is paramount to useful AI models. Thank you.